Hello, my name is Alex Breen, and this is a little introduction to some of the work that I've been doing over the last few years with my collaborators, analysing the mechanics of the lumbar spine. I've also worked in prosthetics and the cervical spine as well, and looking at the muscle metabolic rates and muscle activity. But this talk is going to focus just on the lumbar spine and the use of video fluoroscopy, which is a standard hospital piece of equipment to analyze the spine mechanics in conjunction with some control protocols and image tracking software. These videos here, I hope I am pointing in the right direction, are what I would hope, or an example of what I would hope our techniques would become. These are animations based off my spine mechanics. This is a generic spine, so it's just a model, and hopefully you're seeing the vertebra lighting up, the idea of which is that it could be used in a clinical tool to express or highlight to clinicians, or for clinicians to highlight to patients, or researchers to highlight to one another the mechanics of the spine and where things may be aberrant, or places to focus on. I did have an idea at one point of creating a diagnostic package that would create these animations so it can be used in a clinical setting. But at the moment, these are just examples. So my background is one of medical physics and biomechanics, which has put me in good stead for my roles as a researcher, using quantitative fluoroscopy to measure spine mechanics, as well as a lecturer in biomechanics, research methods, imaging physics, and basic physics as well. In my old institution, the AECC University College in Bournemouth, we had a centre for biomechanics research where we had a programme of work which focuses on the mechanics of the spine at the level of the individual joints themselves. The idea was to investigate the topics of biomechanics and joint degeneration and neck or low back pain, both separately and with an eye to find out where they may interact. We've had some successful publications. These are some of our more clinical focused publications where we have found, we've demonstrated linkages between spine mechanics and back pain. We've also done some work with mechanical models and investigating the relationships between muscle activity and the mechanics of the spine in vivo. The way that we investigate the spine mechanics with high accuracy is by using advanced imaging techniques such as low-dose video fluoroscopy and guided motion using to make sure that patients and participants are all doing the same motion, removing behavioral factors, and then a small computer program which is a bespoke image tracking software to accurately measure the motion of osseous or prosthetic structures in vivo. So these are some of our quantitative fluoroscopy protocols in action. You see here the controlled motion of our participants. I've not put the fluoroscope in these videos so you can see the motion of the participants, but usually a fluoroscope would be a C-arm which will go around the participants, having the intensifier as close to the participant as possible to remove any image distortions. This does require the use of X-rays, as it is fluoroscopy, to create these sequences, which means we have to be very specific with our research questions and the justifications for its use. However, in the table here, you can see the mean and upper third quartile doses for these sequences. These sequences run from approximately 150 to 350 images per sequence, depending on the range of motion that the participant goes through. For a patient, we would usually use a combination of 4 of these sequences. And with any 4 combinations, we'll find that our radiation dose is less than 1 millisievert for a patient. Comparing this to what you would use otherwise, which would be static end-of-range radiographs, the quoted normal radiation dose for such a sequence would be 1.3 millisieverts. So despite us getting a lot more images, we're able to do it with a lot less radiation dose. So ethically speaking, as long as what you're interested in is the motion of the spine and not any fine details such as fractures or anything like that, then it's easily justifiable to use this technique because you're getting a less radiation dose, but you're getting more information when it comes to the mechanics of the spine. I will also send a full playlist. You can see all the different protocols, and you'll see the motion of the spine and the outputs in these videos. These little yellow templates are representations of our tracking. So we can use these to identify the rotation, the slip, and a bunch of other measures that I will go through shortly. In the past, I've worked together with clinicians, basic scientists, and as well as the industry. Such collaborations are often driven by clinical problems that require a combination of skills in appreciating the clinical impact of biomechanical disorders and skills in using technologies to investigate the biomechanics of the clinical condition. Normally speaking, I've already mentioned this. If you were looking at the range, the mechanics of the spine, you take static images, and they provide you with static ranges, so angular range of motion or translation. These are just some examples of values. And really, if you wanted to find these, you wouldn't need anything of higher quality than these images, which are from a fluoroscope. They're very low quality images, but if you're just looking for the outline of the vertebra and looking at range of motion, you don't need anything more. So this is a much lower radiation dose. However, what we find is the motion, the maximum range of a single segment is not at the participant's maximum bend. So if you were asking how far does a segment bend, taking a static image at end range will not answer this question. You can see in this graph 2 of the 4 vertebral pairs that are measured actually maximize at the place where the patient is maximally flexed. Other 2 measures actually happen well before, and the values you would have got from a static end-range radiograph would be far less than the range of motion within the spine. For L45, the green line, you would have an output of a translation or minus, also opposite to the direction you would expect, 0.5 millimeters. You say very little translation, but in truth there was actually a millimeter's translation in the direction of motion that you would not get if you used a static end-range radiograph. Within this paper we also find that the minimal detectable change in the static radiographs is far higher than our controlled method. I believe there's probably some behavioral factors in there, but the ranges that you're measuring are very, very similar on average. One of the most engaging pursuits of the clinical technological collaborations is the challenge of assessing multi-segmental dynamics from imaging. We've worked with some medical device companies in the past to assess the functionality of spinal implants. Here you can see flexible fusions versus rigid fusions, and we're measuring the mechanics of the spine post-fusion, but we could also look pre-fusion as well and follow that person over time. There are other surgical interventions that we've been approached to investigate include scoliosis and scoliosis surgery. With this technology, we can measure the same things as you can with static radiographs, your rotation, translation, disc height ranges, although we also get the quality of motion when that level maximized, and other things that you would not get from end-range radiographs. Laxity being one is a measure of how fast a single segment moves in comparison to the rest of the spine, allowing us to understand which levels are most free to move. And we found this to be analogous of the neutral zone of the spine in motion. The videos here we're showing sensors of rotation. They only show up when there is some rotation, so a level must rotate more than 5 degrees before we can measure sensors of rotation. But you can see the sensors of rotation moving in the spine. This is something we can also investigate pre and post surgery or intervention, be it a surgical intervention or a manual therapy or exercise, and to see how the spine mechanics changes. And the last one, which we'll focus on a little bit here, is the homogeneity of motion, how the motion is shared across the spine. The reason being is that we've found this to be linked to mechanical low back pain. So in this video, you'll see the person bending forwards, and at this point, there is a anti-directional motion. So one segment starts to extend while the rest of the spine bends forwards. This is a bit of an outlier case. It's not usually this apparent, but because it is very apparent in this sequence, I use it for demonstration. I'm just showing the flexion sequence. So the participant did not know that a signal segment was bending back. As far as they were aware, they were bending forwards the whole time. But a single segment, to allow for motion at other levels, has actually started to extend to allow other levels to flex. And so you can see there is some sharing of motion across the spine. So with those normal end-range radiographs, we can look at that sharing of motion as the percentage contribution to rotation. And in the same fashion, so under this angular range, we've given percentages, how much motion each level contributed. We can do that throughout the motion. And here are some examples of the extremes types of that motion. So this is a continuum of someone bending forwards and back. And we've split it into two measures. So taking all this information, we can break down to two measures: the motion sharing inequality and the motion sharing variability, the lower one. A low motion sharing inequality is all the levels contributing equal amounts of motion. So there's very little inequality between levels. A high inequality is one level that contributes significantly more, or one level that contributes significantly less, or a combination of those, giving us a high inequality between levels contributing more and less. And the other measure is the variability. So how much does that contribution to motion change throughout the motion? We find the variability works, gives you more useful measures when passive recumbent measures, so when spinal loading and muscles are not involved, because there is a top-down cascade at the beginning of motion, so there is a high variability in the motion profile in the weight-bearing systems, but not in the lying down systems. So we have found that this is associated with chronic non-specific low back pain. We find that inequality is greater in patients with non-specific low back pain, and there is a relationship between the inequality and variability and mechanical derangements such as disc degeneration, but only in patients with non-specific low back pain, not in controls. So here we see the results I was just describing. The motion sharing inequality is higher, significantly higher in patients compared to controls. you can, we did a few different measures where lying down, standing up, combining lying down measures of bending forwards and back and left and right. In each case, we find that the motion sharing inequality is higher in patients. So here we show in the lying down sequences, we find correlations between age and degeneration amongst all participants, but we only find correlations between age or degeneration and motion profiles in patients with non-specific low back pain. We don't find these correlations in controls. The only thing that does seem to correlate in controls is motion sharing inequality and the variability of that inequality. But we don't seem to find that amongst patients. Maybe this has something to do with muscle guarding. I won't go into the clinical side of things, as that's not really my expertise. The weight-bearing functions, we find that, again, correlations between age and degeneration, of course, it's the same people, that there is a correlation between degeneration and motion sharing variability, of strong correlation in patients, but not in controls. MSI and MSV, coupled with age and degeneration, may be a part of a complex set of biomarkers for non-specific low back pain. We would need to also investigate things like the chemical and the neuroplastic and psychological effects or sections of back pain, because it is a multifactorial condition. I'd say that, well, people say that back pain is not a disease, it is a symptom of a disease, and maybe we're on our way to finding or stratifying patients where the cause or the effect of that back pain is mechanical. As expected, we also find with increased disruption, such as discectomies or fusions, will also cause an increase in motion sharing inequality. If a level is fused, it is not going to contribute anything at all to the motion, therefore its contribution is zero, and therefore the other levels have to contribute a larger percentage to the motion. We find that we have the red line here, which is the normal or the average motion sharing inequality amongst healthy controls, and you can see these patients with some sort of mechanical disruption are well above that value. We've also collaborated, and this kind of section is probably more for those interested in the engineering and biomechanics side of things. We've collaborated with universities both in the UK and abroad to model the properties of the bone, disc and ligaments and muscular components of the spine to better understand their behaviour. And this has led on to some further work which is currently being undertaken. We've even worked with the European Space Agency to investigate how the effects of microgravity during spaceflight might be counteracted if the unloading of the spine affects the mechanics of the spine. Here we're seeing a participant going into an open upright MRI, but there are also the same participants underwent fluoroscopy too. That paper is currently in preparation. With recent advances providing high quality data such as segmental motion analysis using fluoroscopy, material properties and geometry from cadaveric studies, and three-dimensional MRI and muscular activity from electromyography, it is now a real possibility to link clinical problems to biomechanical measures and formulate or validate industry solutions. Recently, my research interest has been in the building of a normative database, a reference database of spine kinematics that can be used in comparison with the spine kinematics of persons with low back pain that is considered mechanical in nature, or we can use it to understand simply how the spine moves in vivo in a way that can be compared across and between populations. This has led to three main outcomes. Firstly, the discovery of a potential biomarker for chronic non-specific mechanical low back pain. Secondly, the generation of the largest database of normative, continuous, multi-segmental spine kinematics. And this is built of 135 participants who bent in the flexion extension, both weight bearing and lying down. 55 of those did it twice. Another 89 participants bent in the coronal plane, both left and right, weight bearing and lying down. 54 of those did it twice. So we can also not only know what normal mechanics ranges are, what normal mechanics of the spine are, but also how repeatable those mechanics are. And lastly, the images themselves. We've used them to measure the kinematics, but they can be used to drive future research in image recognition. We have identified the position of each vertebra in each image of each sequence. This gives us around about 300,000 instances of each lumbar vertebra that can be used to train artificial intelligence, machine learning, for the identification of vertebra, making the identification of vertebra much more robust, repeatable and quicker, so there's no human intervention and error. There is the processing of these sequences can be much faster. Beyond those three, we also have data from the cervical vertebra as well as kinematics of lower limb amputees, sockets and limb interaction. There's a wealth of secondary data amongst this normative database, and I've highlighted a couple there, with the potential to be used to drive future studies. I'm looking for collaborators who wish to use this database in its current form, or use the database for a comparison in basic science or clinical or industry-based questions, or if they'd like to set up their own unit of investigation where I can provide specialist advice or link with providers of equipment such as these motion control devices here on the screen. The kind of clinical queries that we've had so far have been related to things like determining the status of fusions, identifying levels for instability, especially post-fusion, assessing clinical instability of spondylolisthesis, laxity of joints, functional stability of specific levels, maybe pre and post intervention, be that a manual therapy, a surgical therapy, or an exercise therapy, seeing how the spine mechanics changes post-therapy. Also looking at things like loading on discs and the detection of dynamic stenosis. Hopefully that has been an enjoyable whistle-stop tour of my research to date, or a small section of it. If you have any questions, please feel free to reach out to me, and I look forward to hearing from you.